All right, good afternoon and welcome to the webinar. Again, my name is Matthew Menendez with White Plume. I'll be leading the webinar this afternoon for you. Thanks for spending part of your Thursday afternoon with me. I hope this will be valuable and helpful for you. I just want to start briefly with just what I hope to accomplish over the next 50 minutes with you, how we're going to invest our time. My team at White Plume, we've spent the last 12 months working with a variety of practices in different specialties, in different settings, with different EHRs, trying to help clients deliver world-class revenue cycle outcomes. And I wanted to share some of the things that we've learned through our work with these clients because it may be helpful for you in your practice. The first thing we're going to spend some time on is looking at reality. There are a lot of pressures that started last year or before and will continue into 2019 that make revenue cycle work increasingly difficult. We're going to look at what some of those are, but it's nearly universal. I see this in just about every specialty, large practices, small practices, even see some of these troubles hitting outsourced revenue cycle management firms. So I think you'll see that this is some broadly applicable trends that make for some difficult headwinds, right? That put us as practice leaders, as revenue cycle directors, put us in a difficult spot. But I also want to share with you some of the responses we see, right? There are a lot of practices that are just struggling to maintain the status quo. But what I want to share with you are some secrets that we see from top performers, top performing practices. What do they do that's different? How do they handle these realities? And then what type of results are they able to generate? Because what I would submit to you is if these trends continue in 2019 as I expect them to, we're going to see a widening gap between the average performing practice and the top performing practice, right? The rich are going to get richer and the poor are going to get poorer, right? And so I want to share with you what some of those secrets are that we see practices doing to deliver world-class revenue cycle outcomes. I'll make sure that I leave time for questions and answers at the end. For those of you just joining us, welcome. Glad you could make it this afternoon. The slides, the handouts for the slides are in the handout section if you want to go ahead and download those. If you've got any questions as we go, feel free to use the questions panel. I'll try to answer as many of those as I can, either during the webinar or at the very end. Before we get wrapped up, I'll make sure we get finished on time. So let's start by looking at what some of the reality is in the marketplace. What are some of those challenges that we see practices struggling with? The first thing that I think is a near universal truth is there is more work out there for billers and coders to deal with. It may be your practice is adding providers. It may be that you've gone through a merger and so you've expanded the encounter volume that you're dealing with on a daily basis. But there are also other items that are basically new tasks that billers and coders are being asked to deal with. And at the same time, most practices struggle with flat reimbursement rates from payers. Whether it's looking at Medicare or commercial payers, both, there's not a lot of increase when you look at the reimbursement rates. And some people are even facing negative reimbursement rates. And that's a big challenge. For practice leaders, for administrators, for billing managers, coding managers, it's really difficult when you have to do more work for the same amount of money or less, right? You do that over time, and that starts to be a really big challenge for a practice. And a lot of times it's you that gets stuck in the middle. And then the third thing that I think is a trend we will see that continue to increase in 2019 is coding and billing staff turnover. As most of you know, we have record low unemployment rates across the United States right now. Very difficult to find well-qualified billers and coders. The competition for those employees is fierce. You're seeing some new people come into that marketplace, and that makes it really hard to find great people. You know, how long does it take to get a new person up to speed? That's a big challenge for a lot of practice leaders. And so we're going to talk about that, share with you some of the data, share with you some of the trends that we see. But I wanted to give you kind of the high-level overview of where we're going because the revenue cycle work that a practice is required to do is much more difficult than it was 5 or 10 years ago. Even with the new technology that's come in place, a lot of people are struggling with that and have more staff working to create the same amount of revenue that they did 10 years ago. So let's look at a couple of different areas where practices and billers and coders are being asked to do more work. Number one, everybody's favorite, prior authorizations, right? That trend continues to go up and up and up. It's a big frustration point, not only for patients and the clinical staff, but also billing and coding staff who get pulled into that as well. Number two, HCC and risk-adjusted coding. Many of you may not have dealt with that yet. When you start to look at some of the quality reimbursement metrics, when you look at some of the risk-adjusted cost measures, that's where you start to see HCC coding come into place. If you haven't seen that yet, you probably will. I'm going to walk through a little bit of that for you today as well. The third piece that we see as a major driver for more work for billers and coders, kind of outside of their normal scope, is patients' accounts receivable. Right? High deductible health plans continue to increase. We expect that to continue for the foreseeable future, and it's much more difficult, takes much more time, much more labor intensive to collect from patients than it is from payers, right? So we're going to spend some time talking about each of those areas, because if it's not happening in your practice already, it probably will soon. So what we're seeing with prior authorizations is it's basically a denial before the patient's ever been seen, right? Payers are requiring more and more prior auths before the patient is seen, and it's causing a delay in clinical care. When you look at what's happening for patients, it's a frustrating headache that's kind of new in their world, but for practices, this has grown to an area of significant heartburn and headache. On average, you look across the country, there are 29 prior authorizations per week per physician now. That is a lot of work to be managed and takes approximately 15 hours per week per physician. Now, obviously, most practices are not spending clinical resources to do this. That may have been the first step, the first way that you responded to that, have nurses that are going through that process with the payers. But many groups have tried to shift and offload that work off of clinical staff onto administrative staff. I think that makes a lot of sense. Those are usually those resources are usually more available, less expensive. But for those of us on the revenue cycle side, that's a lot of new work on our plate that we have to deal with, in addition to the difficulties of day in, day out reimbursement coding processes. So prior authorizations are something that were a big headache in 2018 for many practices, and probably will continue to grow in 2019. More work for our billers and coders on that front. HCC and risk-adjusted coding is the second area where we'll see some additional work for billers and coders in 2019. For those of you that are unfamiliar with HCC coding, I can give you a very long version of this, but we don't have time for that today. If you've got questions, if you've got interest in HCC coding, just let me know in the questions panel. I can get you some resources that'll help get you up to speed on that. But here is the very, very basic, very, very high-level overview of what HCC and risk-adjusted coding looks like. Right? Everybody knows that CMS and commercial payers are interested in transitioning away from traditional fee-for-service, right? They want to base their reimbursement on quality and cost measures, right? We've seen that with PQRI, PQRS, MIPS, Medicare Advantage programs. That's what the QPP is all about, right? The frustration in that has been you don't understand how difficult that is to measure. Right? Providers have pushback on this and say, you don't understand, my patients are much sicker than the average patient. When you try to compare outcomes, when you try to compare quality, when you try to compare cost, it's not fair because I deal with a sicker patient population than the average physician. And CMS has heard that loud and clear, but they're asking you to prove it, and they're asking you to prove it with the data. And the way that HCC coding works is it looks at the patient or the patient population and assigns a patient acuity score, or an average patient acuity score for a patient population. And there are really kind of two components to that. One is demographic based, things like age and gender, dual eligibility status? Are they Medicare, Medicaid, dual eligible? Are they disabled? Do they live in the community, or are they institutionalized? Things like that from a demographic perspective. But that's usually pretty well documented, pretty well recorded. The other half of HCC coding and that patient acuity score is the patient diagnoses. Most practices do a good job of documenting comorbidities, right? Chronic conditions that have this HCC weight to it. Diabetes, congestive heart failure, COPD, obesity. But they don't necessarily do a good job of coding all of those comorbidities. And if it's not coded, it doesn't count, right? It has to be documented to be coded, but if it's not coded, it doesn't count from an HCC risk-adjusted coding perspective. And so what you see are practices that are starting to deal with this. And it's really about 20% of practices across the country in 2018. That'll grow in 2019. But what they're doing is they're asking their billers, they're asking their coders to spend time looking at the documentation to capture some of those diagnosis codes that carry HCC weight. Again, trying to transfer some of that burden off of the clinical staff onto the coding staff, right? But from a coding perspective, we're being asked to make more bricks without straw, right? More work, but no extra resources. That makes things really hard, right? That's why it can feel like you're running on a treadmill. You're running really, really, really fast. You're working really, really, really hard, but you're not getting anywhere. And that's really frustrating for our teams. The last piece, or the third piece, I don't want to say this is an exhaustive list, but the third piece, the trend that we see, are patient accounts receivable. In 2017, just over 40% of United States households were on high deductible health plans. And the way that the CDC defines a high deductible health plan is for a family, it's anybody with a deductible of $2,600 or greater for the year. For singles, it's half that, it's $1,300, would be defined as a high deductible health plan. So we expect in 2019 that number will be over 50% for the first time in our history. It means more patients than not will be on a high deductible health plan. And the impact that has from an accounts receivable perspective, from a billing and coding revenue cycle management perspective, means we have to work harder to collect those dollars. There is more effort required to collect from patients. There are fewer dollars collected from patients. There are more AR that's written off when we look at patient accounts receivable compared to kind of traditional fee-for-service reimbursement from the payers. And so that means we've got a lot more work to do. You kind of zoom out and look at that. Those three items contribute to much, much more work for billers and coders than what they were doing 10 years ago. So if you feel some frustration, if you hear frustration from your staff, I think that's legitimate. If you hear grumbling from your providers that say, wait a minute, we've got more billing staff than we had before, and I'm having to do more work in my EHR, I think that's legitimate. That's a legitimate frustration. Second trend that we wanted to look at, first one was more work for billers and coders. The second one was really flat reimbursement rates. And you look at this over time, this has a really big impact on our practices. It doesn't necessarily seem like it. We've spending a lot of effort and energy on meaningful use and ICD-10 and MIPS over the last 10 years. But if you look at what's happened with the Medicare physician fee schedule, yes, the sustainable growth rate has been permanently repealed. But if you look at the actual increases that have happened over time, they are very, very small. And another way that practices were looking for additional sources of revenue were from MIPS, right? There were some incentives out there. There were also the penalties or negative adjustments, as Medicare is fond of calling them. But those bonuses never really materialized, or at least not yet. They've been very, very small. I'll share some data with you on that. And then the last kind of change from a reimbursement perspective on the fee-for-service side was the proposed change to E&M payments, right? That was something that Medicare floated out there. It's been pushed out a little bit, but the devil's in the details on that. I want to share some interesting analysis that I found from AAPC on that. So we'll talk through each of those items as well. If you look at the Medicare physician fee schedule over time, look over the last 10 years, yes, you can see we've had a couple of little upticks, cumulatively in the 3.5% range. In 2019, the conversion factor increases, less than 0.2%. So a very, very small increase. But what a lot of people miss is the inflation rate over the same period of time. So yes, reimbursement rates have gone up a little bit, but when you look at that from a buying power perspective and you're seeing additional costs from vendors or from salary pressures, supplies, that sort of thing, the actual reimbursement rates in real dollars actually goes down. This analysis came from the American Academy of Orthopedic Surgeons. I've got the link on the slide, so if you want a copy of the slides when we're done, just let me know in the questions panel. I'll make sure we get that to you so you can go look at the source data. But real dollars over time, inflation greatly outstripped any incremental increases in the Medicare physician fee schedule. So from a fee-for-service perspective, haven't seen a lot of additional dollars. But what about MIPS? Now, you remember the way that MIPS was supposed to work is you would end up with a composite score, right? Again, if you want the full background on this, on how MIPS scoring works, let me know. I can send you a link to another webinar that we've done. But the Reader's Digest version for today is that everybody would get a score from 0 to 100. 100 being the best, 0 being the worst. And there was this performance threshold that would move up over time. It started at 3. It's moved up to 15. If you scored greater than that performance threshold, so the first year, if you scored greater than 3, you would not receive a penalty. You would not receive a negative adjustment. You would receive a moderate positive adjustment, is the words that Medicare used, CMS used when they rolled this out. But there was also these additional dollars that were available if you scored greater than a 75. If you scored greater than the exceptional performance threshold, you were eligible for a larger dollar increase, right? Most people, the way that ended up working for them was most people fell in that middle category. They were able to successfully avoid the penalty, right, which is good news for most people that avoided the penalty. The bad news is that this program is a revenue neutral program to Medicare. And when you hear that, what that means, revenue neutral means the government is not funding the program. Medicare is not funding the program. They were actually taking money from the, quote, losers and redistributing it to the winners from a MIPS score perspective. And since there were not very many losers, there were not very many people paying the penalty, the pool of available dollars for bonus was very, very small. So the maximum bonus that any individual provider or any individual practice received without exceeding the exceptional performance threshold was 0.3%. So 0.3%, right? And if you, again, think about that in context of what the Medicare physician fee schedule has done vis-a-vis inflation over the last 10 years, and we still have a revenue shortfall, even when work is getting more and more difficult, right? So talked about Medicare physician fee schedule. We talked about MIPS. The third thing from a revenue perspective that I wanted to share with you is this change or proposed change to E&M reimbursement, right? Medicare announced this initiative to reduce the physician burden on documentation and paperwork, and they said basically we're gonna do away with all of these 5 versions of E&M codes, right? Today you have level 1 through level 5. They have different reimbursement rates. The more complex the visit, the higher the reimbursement. And they recommended changing that into really just 2 levels of service. It was either a level 1 or not, basically. And you can see from the table here, the level 1 went up, level 2, or what used to be level 2 would have gone up, level 3 would have gone up, but level 4 and 5 would have gone down a little bit, right? So 3 of the codes are higher reimbursement, 2 of them are lower reimbursement. But as always, the devil's in the detail. And there's a great tool available online for this that the American Academy of Professional Coders put out. Certainly recommend going to check it out. It allows you to put in actually a volume of encounters, right? It lets you put in your E&M distribution to see what this change, what that would look like, right, for your practice, what it would look like for your doctors. And so what I did was I actually used the Medicare average for primary care physicians. Here's what their E&M distribution looks like. You can see that in the second column. And then under the current rule, right, that might be $93,000 in reimbursement a year for Medicare patients. Under the proposed reimbursement, I'm sorry, I got that column incorrect. The far right column is the proposed new E&M reimbursement. You can see that's actually a 2% reduction, right? So while it may remove some of the administrative burden, right, assuming that the other payers follow suit, it's still a negative from a take-home pay perspective for those physicians. Now, you might argue that with the reduced documentation burden, they'd be able to see more patients, and that would make up for any sort of shortfall. But this is one of the concerns that a lot of people have had, a lot of advocacy groups have had about the proposed change to E&M payments, right, is that this is actually another kind of hidden cost to practicing medicine. And so when you look over the last 10 years at what's happened, we've had very, very small increases to Medicare physician fee schedule. They haven't kept up with inflation. So you actually got a decrease there. Any upside from MIPS has been very small, has not materialized yet. And then this change on the horizon that won't take effect at the earliest until 2021. But that proposal actually reduces reimbursement for many practices. It will depend on your E&M distribution. There are some practices that could see that as a potential, uptick for their reimbursement. So something to be on the lookout for. I'm going to move quickly. Just want to make sure that we leave plenty of time for Q&A at the end. The last major category for challenges that we see from revenue cycle trends that expect to continue in 2019 are some staffing challenges. As everybody knows, we are now at a 10-year low from an unemployment rate across the United States. That's good news for most people from a labor perspective, but that means if you're looking for somebody to join your revenue cycle staff, they are probably coming from another practice, right? They're probably already working, and you're going to have to hire them away from another practice. That's obviously puts significant pressure on wages. You probably have to pay them more than you would normally to get them to leave one practice and come to yours. But we're also seeing at the same time where there's very, very low unemployment, there's growing demand for billers and coders, right? You can look at the projected jobs increase between now and 2026. That's projected to increase by 13% for billers and coders. There aren't enough people filling those spots. And there are new people coming into this market. You see a lot of the EHR vendors that are starting to set up their own services organization. Now, I've seen some large practices that actually get really, really good at their revenue cycle process that start to outsource some of that work from other practices. So they'll find other people in their specialty, other practices in their community, in their state, that they actually take on those billing and coding responsibility for it because they've gotten a very good process down. So you're starting to see some new people come into that who are trying to hire away top talent, right? And so you've got to think about what happens when I lose one of my best billers and coders. How long is it going to take me to recruit, interview, hire, train, onboard, get them up to speed, right? That is a very, very costly process for practice leaders and managers. So you put all of those things together and you say, yeah, it seems like revenue cycle work has been hard. It has. It has. It is much harder than it was 10 years ago. There's more work for billers and coders. Reimbursement rates are flat at best. They're probably slightly down when you adjust them for inflation. And then with coding and billing staff turnover, right, it's very hard to recruit, retrain, get people up to speed on that. And we don't want to keep solving the problem with more and more people, right? That's a very, very difficult way to fight back against these realities in the marketplace. I don't want to be all doom and gloom. There is good news out there. I have seen some incredible creativity from a lot of forward-thinking practices, from a lot of forward-thinking revenue cycle management firms, as they start to look for ways to fight back against some of these trends. Right? So I want to share just some secrets, share a couple of stories with you of what I've seen over the past 12 months that may be really helpful for you. Because here's where a lot of the point that people have to get to is that sometimes the practice administrator, the billing manager, the coding manager, you feel stuck in the middle, right? The doctors feel the squeeze from a reimbursement perspective. And they see that our revenue cycle staff, we have more people working in the billing office than I did 10 years ago, right? And then you hear from the revenue cycle team, hey, we're being asked to do a lot more work. We're spending time on prior auths. I'm spending time doing chart reviews. I thought all this stuff was going to come through automatically in the EHR, but it doesn't. You know, I'm frustrated with I spend as much time doing that as I used to in the old days, right? So what do? You don't have to sit back and take it. There are ways that practices are fighting back against this. So I wanted to share just a couple of those stories so you can hear how these leaders are turning their revenue cycle into a strength. The first thing that we're seeing people do is they're leveraging their existing EHR and PM platforms, right? We're not seeing as much churn in the marketplace as everybody expected. Looking for how do I make my existing platform better? The second thing that I'm seeing people do is they're using revenue cycle analytics. They're looking for data that can give them insight into what their billing and coding teams are doing, and specifically looking for where there are opportunities for improvement. If I can take actionable data, right, I can work smarter, not harder. And then if I can do those two things, and I can automate some of the lower functions of my revenue cycle on my existing platform, that's a win for us as an organization. And my team loves working on these types of projects. So if you've got questions, feel free to ask. I'll make sure we get somebody in touch with you if you've got particular challenges that you need help with. Love to hear about those. So let me share some of what we're seeing. Leveraging existing EHR platforms, the meaningful use era is obviously over. We've all lived through that. But I want to share with you kind of what we're seeing people do now that that's behind us. What are they doing? Because EHR replacement rates are much lower than what a lot of the industry analysts projected. You're seeing that in some of the quarterly earnings calls from EHR vendors. It's really, really interesting to kind of listen to that. But when I think about the implications that has for practices and for their revenue cycles, I think there are opportunities there. And seeing some of these forward-thinking groups get there, I know that's possible for other people too. And what they're able to do is actually get the return on investment that they were never able to unlock from their EHR implementation. They're able to leverage some existing and other tools, resources, analytics to be able to actually get there. So let me spend a little bit of time talking about that. The frustration from a revenue cycle standpoint on meaningful use is that we really expected it to be a boon to the revenue cycle, right? If doctors would document correctly in the EHR, we could automate that coding process and we'd get a lot of return on investment. We'd get a lot of time savings there. But that really hasn't materialized. In fact, through our work with practices, we find that over 30% of practices still use a paper charge ticket or a paper super bill. Variety of reasons as to why. It may be frustration with their EHR. It may be frustration with the physician. It may be a little bit of both. But we see that all the time. And that means we're still doing that manual charge entry work to our practice management system. There has to be a better way to do that. And even a more ubiquitous problem that we see, and over 8 out of 10 practices that we talk to, they have more, or at the very least the same number of revenue cycle staff that they did before they implemented their EHR, whether that was 5 years ago or 10 years ago. They haven't been able to unlock that return on investment, right? So how do we do that? What do you try to do to try to automate those parts of the process? I'll tell you a story just when we look at this of where we've seen some savings. So billing and coding staff, right? They're trying to get claims out the door as cleanly, completely, correctly as possible, right? And that can be really complicated in a large specialty-specific practice like Andrews Sports Medicine in Birmingham. They had a problem with some of their DME, right? So they would have braces and boots and splints that just walked out the door, on a patient that they were never charging for. So our team worked with their EHR vendor, worked with their DME supplier, DJO, to integrate a coding process that said, okay, we can get the office charges, we can get the DME charges, we can combine those electronically so that they'll actually go out the door on the same claim so that we can have better coding outcomes with less coding time, so that we're not manually coding all of those DME charges and that we're not missing any of those revenue opportunities, right? So rather than going out and saying, I need to go look for a new EHR, right? Or because that's not a very productive way to actually achieve that return on investment. 70% of practices report that they are unlikely to replace their EHR, even though they're frustrated. Even though there are things that you don't love about your EHR, it's a bit of the devil you know versus the devil you don't know, right? Think about the transition cost, the transaction cost associated with taking one EHR out and putting a new EHR in. You may have some of the exact same problems, right? But you're spending months on the transition, you're spending downtime, reducing physician schedules, not to mention all of the training and implementation energy and effort to put in a new EHR that may or may not be better than your existing EHR. I think most practices are making a rational decision there, and that's why we see low EHR replacement rates. It's better to look at projects like Andrews Sports Medicine was looking at that says, how do I use my existing systems better, right? Or what can I leverage with those systems to make my revenue cycle work better than it does today? Another thing that I'm seeing some very creative practices do is look at revenue cycle analytics. They're not just looking at denials and AR days on hand. Those are important metrics, but they're starting to actually look for things that are a bit deeper in the practice. They're looking at biller and coder productivity metrics, right? You may, off the top of your head, know who your most productive revenue cycle staff are, right? But can you quantify it? And even further, do we know exactly what they're doing? What makes them the most productive? What makes them the most effective? What types of coding changes are they making behind the physician? Which of my physicians are we having to make the most coding changes for, right? And why? Because if I can get underneath that data and identify opportunities for improvement, right, then there are opportunities for us to leverage best practices across the organization. And that's a big frustration for a lot of practice administrators, for a lot of revenue cycle directors. It's really frustrating not to have a lot of visibility into the revenue cycle process. Right? I've got lots of data on, how many RVUs and how many CPT codes and how many encounters and what are our AR days by payer. But when I look at what my billers and coders are doing, it's really hard to see. And that's frustrating from a management perspective, right? How do I benchmark that? Do I know if we're doing well? How do I compare to my peers, right? And if I can't see that in the data, if I don't really have a good grasp on that, when I have turnover, it makes that risk much, much higher, right? And so we love working with clients on this. We found this is the key to unlocking a lot of that return on investment in our solutions and in their revenue cycle process within their EHR, is using these types of analytics. Let me give you just a quick story. Let's just imagine you have just two billers on your staff, right? The names have been changed to protect the innocent, Alice and Barbara. All right, you probably know what their encounter volume looks like on a monthly basis, right? You probably know Alice does a little bit more work than Barbara, but Barbara keeps up pretty well, right? But a metric that you may not know is how many encounters per hour can each of them handle. And this is real client data. I've just changed the names. But looking at how efficient, how effective, how productive are they? And that's not to be used as a punitive measure for Barbara, right? I need visibility into what my team is doing, right? So what this suggests to me is Alice can process 108 encounters per hour, and she has to make coding changes on 52% of those encounters. Barbara is making a very similar change rate. She's actually changing more encounters per hour, but she is much less efficient and effective in her work. You know, she may be changing some things that are unnecessary, right? There may be some old habits that exist, some coding changes that we're making that really don't matter from a reimbursement perspective, right? And again, I don't want to use this data to beat Barbara over the head with. I want to be able to see what my team is doing so that we can identify opportunities for best practices. We love working with clients on this because there are real results that go along with this, right? The opportunity here is if we can leverage what Alice already knows and share that information with Barbara and do some very targeted training, we can save Barbara 4.5 hours per week. Right? If you've got a larger staff and you spread that out across 8 or 9 people, you know, now you're talking about saving 40 hours per week. So that we can start to fight back against some of those other tasks that are being assigned to our revenue cycle teams, like prior authorizations, like HCC coding, right? Where do I find the extra time? I don't have to go out and hire additional people, but I do need effective tools to make my current staff more productive. Right? Does that make sense? So when I look at revenue cycle analytics, what I'm after is I'm looking to get visibility into what is happening. I want to mine that data to find the best opportunities. Now I'll share another client story with you, something we saw in 2018. Large cardiology practice, over 50 providers, and they capture charge data through their EHR. They are good users of their EHR, but we started to measure this encounters per hour on a monthly basis and would review the data with their leadership team and then provide some targeted training on how they could better use some of our applications so that they could use it less, not more, so that they could be more productive, so that they could be more effective. And over the course of 2018, they had 138% improvement in their encounters per hour per coder over their entire team of 14 billers and coders. Let me see if I can say that another way that may kind of help you understand what the impact of that is. They had a 17% increase in their encounter volume during 2018. That's a great year. And they were able to do that work in 864 hours less every month. Using the analytics to identify the best opportunities for cross-training of your people saved their team 864 hours a month. Right? That's how you fight back against some of these revenue cycle challenges, some of the realities we face in the marketplace. Right? It allows your leadership team to get their hands around what's happening. Not to penalize your people, but to empower them. Right? Because we want them to be as productive as possible. Right? We want to make that revenue cycle outcome a world-class outcome for your practice. And part of what that means is looking for opportunities to leverage the team. We've got to go not just exception-only coding. We want to go beyond that. Right? We want to look for times where we can not only have maximum accuracy from a coding perspective, right? We want to do that in the least amount of time possible. Because what that allows your people to do is focus their time, energy, and effort where their expertise is most valuable. So we're talking about how do you automate some of those lower level tasks. And using analytics as a tool to identify those types of opportunities is exactly what you want to do. So just to give you a quick idea of what that looks like, traditional coding review, typically that means you've got a coder, you've got a biller who's reviewing every single encounter. And most practices that do that have very, very good results. But practices who can do exception-only coding, meaning they only touch the ones that have a problem. Right? You may use a code scrubber or a code editor to help you get some of these edits and stop and get your attention on the right encounters. Right? Exception-only coding process is a great thing to do. But I would challenge you want to go beyond that and really focus on revenue cycle automation. Moving from left to right, yes, you can have high coding accuracy. You can have low denial rate. You can have low accounts receivable days. But it's going to be a very labor-intensive process. Right? You probably have more people than you'd like going through that part of the process. How do we make those great people more effective? Exception-only coding is a great first step. You can still deliver highly accurate coding results. Low denied claims, very few missed charges, but you can do it in a fraction of the time. But the best way to do that is to start to automate some of those lower functions on that end of the revenue cycle. Now, this is as much a mindset change as it is anything else. Right? It's not just a technology change. It's people, process, and technology. And sometimes, if you've got really experienced coders, that mindset change for the coders can be one of the most difficult things to change. Because they are used to and they have been rewarded and praised for touching every single encounter, finding all of the problems, and making all of those corrections. But if we're looking for opportunities to automate, right, we're looking for opportunities to leverage their time. And what I would tell you is when we look at this, analytics can be a big, big piece of it. Another client example, we worked with a large orthopedic practice in Georgia and started to look at their analytics and noticed, we had a quarterly analytics review call with them where one of our trainers could be on the call looking at the data and recommending some best practices that we've seen from other groups. And what we noticed, the anomaly was they were making a lot of diagnosis changes within our application. It was close to 800 800 a month diagnosis changes that looked unnecessary. And so the data often helps you ask better questions. It doesn't give you all the answers. And so in starting to understand the workflow and talking with the coders to understand what was happening, it became clear that it was basically they were adding a dummy diagnosis code for a strange practice management system requirement on certain types of encounters. And so And understanding that they all had a little bit different process. It was one of those things that they had been trained by the person who did it before. And what came to light was, well, that's something that we can automate. It doesn't require coder intervention. There's not a lot of decision. There's not a lot of complexity there. It can be automated, and we can reallocate some of that coding time to the higher value functions where those coders' expertise is actually required. And so using analytics, kind of bringing that full cycle to find those types of opportunities for revenue cycle automation is huge when you're trying to push back against some of those headwinds that we face, across our industry right now. So let me zoom back out before I turn to questions and answers. We see revenue cycle trends of more work for billers and coders, right? Bar none. It may be something different for you. We see those being the big three with prior authorizations, with HCC, risk-adjusted coding, right? We see that with high deductible health plans, more work for billers and coders as they continue to try to serve their doctors well. Take that off their plate so they can focus on taking care of patients. Great, right? But that means more work for our staff. Doing that in an environment of declining or flat reimbursement rates is very, very difficult, right? Being asked to make more bricks without straw. And then doing that with a revolving door in your office. If you've got high turnover, if you've experienced that, you know how challenging that can be as a leader in the practice. Most practices face those types of headwinds. What we're seeing is the difference is that the top performing practices are trying to push back against that, right? They're looking for opportunities to leverage their existing platforms, right? That's why we integrate with their EHR. They're looking for analytics to be able to show them not just a software solution, but how to use it better to make their people more productive, right? If I can save 800 hours of billing and coding staff time this year, think about all the other things that we can do that we've never been able to get to on our punch list. And then if I can look for opportunities to automate parts of that process, then I'm really doing something. And when you look at the results across our entire client base, the average biller or coder can handle 25 to 30 encounters per hour. At the beginning of 2018, the average White Plume client could do 107 encounters per hour, 3 times more productive. But the thing that I'm most proud of is over the course of 2018, those same practices, just by leveraging the data, became 54% more productive, up to 143 encounters per biller per hour. And what that means is the rich are getting richer and the poor are getting poorer. It's really hard to maintain the status quo in face of these realities, right? The average practice, their revenue cycle is less efficient, is less productive than it was 5 years ago. But with the right response, with looking for the right opportunities, the top performing practices are doing much, much better. And I'll leave you with one last story before I open it up and try to answer the questions in the question panel. The last story is something that I think is really interesting. And I've seen it a couple of times. I've seen practices who are looking for these types of opportunities. And they've gotten much more productive, right? And so what you'd think is, well, if they're 3 times more productive than they used to be, I guess they fired or let go or didn't hire after attrition 2/3 of their billing and coding staff. And the thing that I think is really cool is that they didn't do that. Instead, they looked at their revenue cycle process and realized that it wasn't a cost center, but it was a profit center for them. That if they could be 4 times more productive than they were before, that they could go and sell those services to other practices in their specialty. That they could go offer to outsource some of that billing work for other practices in their community. And they could do that in a way that was both profitable for them as a new revenue source, right? And less expensive for those average performing practices to outsource that to them. Very creative, very interesting. Right? I expect that we'll see more of that over the next couple of years. And if that, you may not want to turn that into a, outsourced MSO for your particular practice. But what I would encourage you to consider is, how do you make your practice more productive so that you can handle your own work better than where you are today, and so that you can fight back against some of these realities. All right, thank you so much for your time. I really appreciate it. I wanted to make sure I saved about a couple of minutes for some of those questions and answers. I'll pull up the panel. Again, remember to use the questions panel if you've got follow-up information requests, if you'd like to see a recorded version of the webinar, if you would like to see the slides or any kind of additional information, have any additional questions, feel free to use the questions panel for that. Okay, let's see here. First question is, sorry, I was a little confused. So are you, is White Plume an analytics company? No. That's a great question. No, we're a software development company. We have products that automate the charge entry coding process alongside your EHR, alongside your PM platforms. The reason I talked about analytics is, we found that without that type of data, and without, honestly, some consultative work alongside of the data, that our practices don't get the full value out of those, out of our applications. And so that is something that we've started doing over the past couple of years, to really try to help our clients get the full value out of our software platform. So great question. Thanks for asking about that. Somebody asked about HCC coding. Is that something new? I hadn't heard of that before. No, it's not something new. It's been around for it's been around for 13 years now. Originally started in the Medicare Advantage world, so that those Medicare Advantage plans wouldn't cherry pick the healthiest patients. But it is now the kind of preferred risk-adjusted methodology that CMS uses for, they used it in the value-based modifier program, several years ago. They use it in some of their risk-adjusted cost measures under MIPS. It's used for ACOs under that part of QPP. They also use it for bundled payment programs that are risk adjusted, and you see the commercial payers pick that up as well. So if that's something that you haven't seen before, you probably will see it in the not too distant future. And if you want more information on that, we've got some blog posts and some recorded webinars that we've done on HCC coding in the past. I'm happy to share that with you. Just let us know, and we'll make sure we get that to you as well. Okay, I'm right up at the top of the hour. I want to be respectful of everybody's time. I'll answer those other questions offline, and I'll leave the questions panel up for a few minutes in case there are additional questions that you have. Otherwise, thank you again for your time. I greatly appreciate it. I hope this was valuable for you. Please take the 30 seconds to answer that 3-question survey at the end. That helps me make these webinars as valuable as possible going forward. Thanks. Have a great rest of your Thursday. Bye-bye.